And hello, thank you everyone for joining us today for this test case session. We'll be talking and discussing the test case entitled Estimating and Validating Diagnostic Cancer Biomarker IVD Test Panel Characteristics and Clinical Utility for Indeterminate Pulmonary Nodule Risk Stratification in patients with lung cancer. I'm Dr. Pablo Salcedo. I'm a research scientist here at NEST. So our panel participants today, including myself, we also have Dr. Deppen. He's Assistant Professor of Thoracic Surgery and Epidemiology at Vanderbilt University Medical Center. We also have Dr. Soma Ghosh, and she's the Chief of Molecular Pathology and Cytology of the RWE² at the FDA. And we also have Dr. Christopher Eger, who's Medical Officer of Respiratory Devices at OPEQ FDA. So some overarching facts about this test case. The available data sources used in this test case included electronic health records. The duration of the test case was about 12 months. And the disease area of focus is oncology. And our device or technology of interest was a blood-based biomarker IVD test panel. And for this test case, we had 3 network collaborators. We had Vanderbilt University Medical Center, Leahy Hospital Medical Center, as well as the One Florida Consortium. So test case relevance and criteria for selecting this test case. Not only does this test case utilize real-world data to measure the clinical utility of this IVD test panel in stratifying suspicious lung nodules, but it also takes that real-world data and combines it with a small validation study. And this device in particular is important to the medical device ecosystem and NEST because of the prevalence of lung cancer in our society, as well as the heavy disease burden. Lung cancer causes more American deaths than prostate, breast, and colorectal combined. And given that early detection and prevention is key to minimizing morbidity, and non-invasive biomarkers are one avenue that can minimize unnecessary invasive procedures by stratifying these indeterminate pulmonary nodules into both low or risk high categories and improve the management of indeterminate pulmonary nodules. And in this test case, NEST's role was to facilitate communication between all collaborators on study progress, administrative progress. Deliverables were monitored and collected, including preliminary, final reports, as well as having a data scientist on board to help clarify any technical questions and to ensure that data quality and compliance was reinforced. And so now we'll discuss a little bit of background information on the disease area of interest, as well as the technology of interest. So IPNs occur over 1.6 million annually, and IPNs are typically classified into low indeterminate risk and high risk indeterminate pulmonary nodules, and those that are classified as intermediate or indeterminate usually require extensive testing. And as a result of the lung's difficulty to be assessed, there are complications that come along with extensive testing, including lung collapse, lung failure, bleeding, and potential death. So being able to have a device of interest that can minimize these imaging and procedures is very beneficial to the patient population. In addition, there's currently no FDA approved or cleared blood tests to diagnose lung cancer in patients with IPNs. So a little bit about the actual IPN IVD test panel that was used in this test case to stratify IPNs into high or low. It consists of 9 biomarkers, 7 are tumor-associated markers, 2 are acute phase reactants. So why submitted for a NEST test case? One point being the opportunity to include rich data sources. This is not limited to electronic health records, administrative claims, as well as registries, all which combined allow us to get substantial uniform data on a diverse patient population across broad hospital and clinical sites. In addition, we can achieve more study goals and increase data capture by substantiating with larger sample sizes. This allows us to detect differences in infrequent clinical outcomes. And then for instance, in this test case with Abbott and the IVD test panel, the additional sample size and test characteristics were able to be used to create a simulation that tested IVD sensitivity and specificity. And now I will pass this over to Dr. Stephen Deppen, and he's going to tell us more about the study design.
Thanks, Pablo, and thanks everyone attending this session. My name is Steve Deppen. I'm an associate professor of thoracic surgery and epidemiology at Vanderbilt. First, I want to introduce our team. We had Dr. Richardson Davis from Abbott, Dr. Rega Chris from Leahy, and the team from One Florida, Professor Go, Jennifer Woodard, and Professor Ban, as well as Pablo from NEST. So as mentioned before, this was examining a potential blood test for diagnosis of lung cancer, indeterminate pulmonary nodules. For hereafter, I'll call them IPNs. Existing tests are generally indicated only for a limited range of risk. And there's very limited data on the clinical utility of these tests. And so understanding these two pieces, both how we could address the question of clinical utility and how tests might actually be used at the bedside. So the clinical question that we have at hand really is the dilemma facing clinicians who are seeking to diagnose and evaluate IPNs. There are 1.5 million incidental discovered nodules occurring every year. And these are, as I mentioned, incidentally discovered. This number will be increasing as lung cancer screening becomes more pervasive across the United States and the world. And each one of these nodules that must then be followed and diagnosed eventually. There are limited non-invasive biomarkers to diagnose cancer. Primarily what we have is imaging, namely FDG PET. However, PET is much less specific in large regions of the country and the world in which infectious lung disease confounds the diagnosis with FDG PET. In our region of the country, that's histoplasmosis. In the Southwest, it's capsuloides. In other parts of the world, TB. Furthermore, complications from procedures limit the utility of simply aggressively going after all nodules because of the sequelae arising from those invasive procedures. So what clinician has to balance is the time to diagnosis, what they're trying to minimize for those individuals who happen to have cancer, as well as avoiding unnecessary invasive and costly procedures in those who have benign disease. So first of all, I want to describe briefly the three institutions that collaborated on this project. Vanderbilt is a multi-clinic tertiary referral center, a large academic medical center. We have a common data model, a research and synthetic derivative, which uses OMA. We evaluate over 10,000 IPNs a year. It's also one of the national biomarker validation sites, the Early Detection Research Network, of which I'm a leader of the Thoracic Biorepository. This was one of the advantages and one of the reasons why Abbott was very interested in working with NEST in the project. And finally, of note, especially as we talk about this further, about 10% of the IPNs within this data set are arising from lung cancer screening. The other collaborator was Leahy Medical Center, which is an internationally recognized leader in lung cancer screening. And this unique population of a large lung cancer screening group really gave a bit of diversity to the populations in which were utilized for this test, in this test case. Specifically, they have 22 participants from the Boston area, and everyone that Leahy provided for this, all the IPNs discovered were within a screening population. They also have a very dense set of data they collect on all of their participants in their screening program. And finally, One Florida is a large network consortium of over 12 hospital systems across Florida, representing millions of individuals across the state. It's also directly associated with the University of Florida. And so that combination of the breadth of coverage of the clinical records, also a very diverse population compared to Vanderbilt as well as Leahy, also allowed an interesting contrast, which we'll see again in the results later. So generally, the four aims for this project was first to create a multi-institutional cohort of IPNs, put them into a common data set and make them available for analysis. Second, to link those individuals and determine the clinical effort and create an algorithm executed through the common data models at each institution that would then call through the EHRs to determine the clinical activity necessary to achieve a diagnosis for each one of those IPNs. And then using that data and some simulated data provided by Abbott, we were able to examine through simulation how it might best be used for the diagnosis of cancer. And then finally, we did a small validation study using the information gleaned from AIM-3 to determine what that might look like in real life. So more specifically, we had a retrospective cohort of individuals across the 3 sites. The baseline risk model that we used was a Mayo Clinic model. This is the model which is in the guidelines for the ACCP. That model utilizes age, smoking history, whether or not there was a history of cancer, the location of the nodule in the lung, the size of the nodule, and the nodule shape. These were all collected from each of the sites. And then for the second aim, that diagnostic activity, an algorithm was developed through an iterative process and deployed at each one of the sites. The clinical activity that was counted was radiographic scans, various types of biopsies, FNA, whether CT-led or full thoracotomy, thoracoscopies, as well as time to diagnosis. The algorithm was based on a variety of CD and ICD-9 codes and was later verified by chart review of the subset. In AIM-3, we then took the biomarker-based model, linked it to the EHR data, tested various combinations of the model within the data to come up with simulations of how it might be used in real world within a subset of that data. It utilized both machine learning and logistic regression models to fine-tune it through simulations. And then finally, 500 individual samples were sent to Abbott Labs for testing, 50 from Vanderbilt, 50 from Leahy. So we have 2 very diverse populations, Vanderbilt being an incidental population, Leahy being a screening population. Biomarkers were completed on all samples, and the validation results examined. Our general results, we had over 2,100 individuals linked from the 3 sites after our set of exclusion criteria, primary of which was limiting the size of the nodule to between 6 and 30 millimeters in the age of 40 degrees to represent a cohort of individuals with primarily intermediate risk. That's in the 10 to 70% range, which is based on the British Society's, British Cancer Society's limits of what they consider low, medium, and high risk. The prevalence of cancer was lowest in the screening population, highest in the Vanderbilt population. Vanderbilt was primarily from the thoracic surgery clinics, as well as an interventional pulmonary clinic, and was slightly lower in one Florida. The EHR-based algorithm generally undercounted clinical activity, as we can see here displayed in table 1, where the first number before the slash is the algorithm average, and then the number after the slash, which is in the chart review, which occurred in 50 individuals from Leahy, 50 from Vanderbilt, and 53 from one Florida. We see the difference in numbers for each broad category of diagnostic activity. So generally, as we want to think about this, what is driving these results that we see, why we see such large differences in certain subsets, can really be defined by the population and the referral patterns and the data patterns within each institution. So Vanderbilt is a tertiary medical center. Much of the clinical workup actually occurs outside of our system. We don't see that, although it is captured in the EHR, not in commonly structured data, but is available unstructured. And unfortunately, especially in some of the older patients, is lying hidden in PDFs scattered throughout the EHR. So what we see here, if you look specifically at the bronchoscopy number in the Vanderbilt population, we see that low proportion of bronchoscopies as a procedure, and even worse, the CTs. So again, as that diagnostic process occurs, it's discovered on the CT, and then say we probably have a non-diagnostic or a failed bronchoscopy, and then we get the referral for that patient. And that's what we're observing here. In Leahy, at the opposite end of that spectrum, we have a population in which the vast majority of their care is both initiated and followed up in the Leahy Medical Center. And we see, for example, perfect capture of the number of bronchoscopies, a little bit less in diagnostic procedures, which maybe they go elsewhere for their surgical procedure and treatment. But we see overall excellent agreement in the Leahy data. So as we think about executing algorithms to capture the real-world data, and by the way, Florida is pretty much in the middle of the two with respect to its accuracy and correlation between the EHR algorithm and the chart review. It really is being driven by how that data is being generated in the underlying population. So as we want to apply this to other institutions, other diagnostic tests or the like, understanding that underlying population and making sure that we have the correct breadth and the accuracy, the right population is really important. So to reiterate sort of the same point, we see a wide variation in the average number of days of diagnosis. We would expect in a screening population in which there's such a low prevalence of cancer, the normal guidelines require 2 years of follow-up. We see the average number of days to get to a diagnosis, whether it's benign or cancer, is 604. This is appropriate clinical care. We'd expect a relatively long time to diagnosis in a population of screening discovered nodules. While Vanderbilt is just the opposite. These are individuals who, in many cases, have high-risk nodules coming in. Previous surgical attempts previous invasive attempts have already been attempted. And so getting to a diagnosis becomes a priority, and the average days, even though it includes individuals with screening discovered nodules as well, is much lower, with Florida in between the two. As we look at that sort of initial analysis using some machine learning methods with the biomarker model, it had an area under the curve of 7.7, and that compared to the Mayo model estimate of risk of 0.64. In the validation analysis of the same biomarker held to the initial training values, AUC dropped, not a lot, but slightly to 7.3, with much poor performance occurring in the lung cancer screening population. And so this is the captures our simulations, which I want to spend just a minute on. And on the x-axis here, in each one of these confusion plots, what we have is the Mayo Clinic risk model with values from 0 to 100. Our cutoffs here are actually marked at the 70 and 10% levels. And then it also has a calibration adjusted estimate of the risk from a proposed model with Biomarker, which is on the y-axis. And so if we were to look at this individual in the green, they have a Mayo estimated risk of below 10%, while the biomarker score put them at about 20%. And this is an individual in the cancer. So in this case, the biomarker did a better job or improved the diagnostic evaluation of that IPN. On the other hand, we might have someone who in the far right of that same graph had a Mayo risk estimate of about 85%, and the biomarker decreased that estimate to 65%. And we see the biomarker actually performed better in those with benign disease, correctly reclassifying those 6 overall, with misclassification occurring in none. Again, what I want to reiterate is that this is simulated data. The purpose of this process was not to generate a final submission to the FDA, but to show proof of concept of linking real-world data to possible actual diagnostic test characteristics and to help determine where those cutoffs should be and to help in the diagnostic test development and validation process. So in conclusion, the test case demonstrated the ability to utilize real-world data to both characterize and prototype an in vitro diagnostic assay. The data that are generated from this are going to be used to fuel the next iteration of the assay development as the assay becomes more refined in the future. There were significant differences that we observed across sites as well as the final results. as it was tested in a high prevalence cancer population. And in the population in which it performed poorly, it had a much lower prevalence of cancer. So understanding that and working with that will also help indicate the population in which such a diagnostic test might be used. And finally, as we move forward and think about adding machine learning, especially in the use of machine learning-based imaging models, that as well as the epidemiologic endpoints which real-world data can provide will make this approach and these models and clinical decision support tools much more powerful. Thank you for your time, and I want to hand over to Dr. Ghosh with the FDA.
Thank you, Dr. Deppen, for describing the key elements of the proposal. That was very helpful. Hello, everyone. My name is Soma Ghosh, and I'm from the Division of Molecular Genetics and Pathology in CDRH FDA. Thanks for the opportunity to review and comment on this study case. So basically, based on the information that was provided and based on the review, I will try to provide general comments on the study proposal and study aims in the next few slides. And then I will provide recommendations for the future marketing application, because the ultimate goal, as Dr. Deppen described, is development and validation of the IVD for marketing purposes. So at the very beginning, I would like to note that when submitting a clinical study protocol for review, whether it is for hypothesis generation or an early feasibility study or an early phase clinical study, it is important to include the draft intended use and indications for use of the subject test. So the information in the intended use and indications for use is critical for FDA, as important review decisions such as the risk-based device classification and the type of analytical and clinical performance studies needed to support the device claims will be dictated by the intended use and indications for use statement. So let me explain what I mean. So since this device will be used for IPN risk stratification in patients with lung cancer, we will ask the question, what is the outcome of false positive or a false negative result, right? And maybe we would discuss that the false positive result will lead to complications from biopsy, while a false negative result may lead to death or increased morbidity due to delayed diagnosis of cancer, right? So therefore, based on these risks, we would conclude that the proposed IVD will be a high-risk device, and therefore the regulatory path and the studies needed to support the intended use should be determined accordingly. Therefore, knowledge of the intended use or indications for use statement, even if it is in the draft form, is critical for our review. So an important aspect of this proposal, as outlined by Drs. Pablo and Deppen, is the use of the real-world data. And specific aims 1 and 2 describe several objectives that will be accomplished based on real-world data from the 3 databases that was outlined. So you may know that FDA encourages use of real-world data and real-world evidence to support regulatory decisions when data is derived from real-world sources under the right conditions. CDRH and also other centers in the FDA have published guidance documents describing the criteria to determine whether real-world data are of sufficient quality to support regulatory decision-making, including potentially generating valid scientific evidence. And I've provided a link of these guidance documents at the end of my talk. Coming to the use of electronic health records, which has been used in this proposal, there could be multiple limitations. And in the context of this proposal, I will outline a few questions that we had with the use of EHR data. However, for this particular proposal, since EHR has been used for hypothesis generation, we believe that it's generally an acceptable approach. So in this slide, I would like to discuss some limitations of the EHR data. Dr. Deppen's presentation actually addressed some of the questions we had. However, the protocol did not have much clarity. And so I will go over the questions again, and if they are addressed in more detail in next iteration of the protocol, that would be helpful. So we would like to know basically how the EHR data was collected in the 3 sites. So one of the questions we had is, was this data based solely on high-risk screening population using low-dose CT, or was there patients from incidental findings or other populations? Was there symptomatic patients with nodules discovered during workup? And I think Dr. Deppen touched upon those during his course, during his presentation. Therefore, the main question I'm asking here is, the population that was assayed or assessed in the real world data, is that consistent with the IVD intended use population? Another question we had was with the use of the phrase suspicious for malignancy. So it has been used quite often in the proposal. What was not clear was whether the data set composed both suspicious and benign nodules. I think that has been the case. However, this was not very clearly outlined. The other question we had was with respect to the use of two risk models, the Mayo and the Brock model, for algorithm development. And we wanted to better understand how use of these two separate models can impact algorithm development. And another question we had was on the variability between the radiologist readers who are reading the images. Was that data a part of this assessment? In other words, we know there's a lot of variability in the real world. And so when these three different data from three different sites were evaluated, was this taken into consideration? Was there a single radiologist, multiple radiologists? So that was not very clear. So basically in specific aim 4, as outlined by Dr. Deppen, the plan was to perform a small scale research validation study in a prospectively collected plasma sample set of less than 100 patients who were later proved to have lung cancer. However, what was not clear was what was the basis of the sample size. And were these the same samples that were used for algorithm development, or maybe it is from the same sample set, but they are different patients and not the same patients that were used for algorithm development, but those aspects were not clearly outlined. Also, we wanted to understand whether adequate number of malignant and benign cases were used for the algorithm validation. Also, it was not very clear whether the clinical decision point or the cut point of the assay was locked after establishment of the algorithm. And I do understand that AUC and ROC analysis was done for the development, but for validation purposes, we would like to see performance measures like sensitivity, specificity, positive and negative predictive values to understand the clinical validation of the device. So having discussed general comments about the study proposal, I would now like to provide some recommendations for your future IVD marketing application. And here I have listed the main elements that we expect to review in an IVD submission. Next, please. So here in this slide, I've listed some pre-analytical and analytical validation considerations. Since this is a liquid biopsy test, pre-analytical steps are critical. This may include sample collection, handling, processing, etc. And these should be adequately optimized and validated. I also wanted to note that the blood collection tube should be pre-specified, and this should be an authorized or a cleared product. If it is not authorized or cleared, it should be done prior to or concurrently with the approval of the assay. I then wanted to touch upon the analytical validation studies. And again, this is a whole new different topic by itself. So all analytical validation studies should be conducted for all steps of the test, right from sample preparation to results generation, and intended use clinical specimens should be used for all these different validation studies, unless other specified that there is a limitation of the intended use clinical specimen, wherein you may use contrived samples or cell lines, but the functional behavior between the clinical and the contrived samples should be demonstrated. In this slide, I've outlined the clinical study considerations to support clinical performance of your future IVD. You should plan a prospective controlled multicenter study. The target population should include patients with nodules that are suspicious for malignancy, as well as use of benign nodules across different type and size. The eligibility criteria should be clearly stated. The assay cutoff or cutoffs should be established and locked prior to the use of the clinical study. The training and validation data sets should be independent of each other. And very importantly, the study should be designed such that the use of the device is aligned with the instructions for use of this test, as well as it is aligned with how the device would be used in the clinical setting for patient evaluation purposes. The clinical study should really be completely consistent with how the device is going to be used in the clinical setting. In addition, as I mentioned, the sample size should be clinically and statistically justified, and the endpoints should be clearly defined. The performance measures for this type of tests should be in the way of sensitivity, specificity, positive and negative predictive values, and so on. Ultimately, I wanted to note that the totality of the data that is submitted for FDA review, that is the totality of the pre-analytical, analytical, and clinical performance data, will be taken into consideration to inform the finalized device intended use and the labeling documents. And I would recommend that you submit a pre-submission for discussion of the IVD development and validation to CDRH. However, I also wanted to note that at this time, the pre-submission program is not fully functional. We have opened it for a review of companion diagnostic device, but I encourage you to be in touch with CDRH to know when it is fully functional so that you can submit for our feedback. And I have included some resources and tools for your reference. And with that, I end my presentation. Thank you for your attention and thank you for joining our session. We will now open for Q&A.